I am an optometrist. I'm an eye doctor. I have a regular primary care practice where I treat eye diseases and fit glasses and contacts, and I get to work with visually impaired people too. I think overall my general knowledge of just normal vision and abnormal vision has certainly helped me develop some of the things that I've been able to help macular degeneration patients with. I think there's a value to seeing a low vision specialist. There are a few ophthalmologists that do this, but mostly they're optometrists. We have a little bit more training in it in school, but most of my ophthalmology and optometry colleagues really don't have much interest in low vision. But typically, eye doctors are in the business of making people see 20/20. I'm in the business of being happy if somebody can see 2200 and teaching them how to use their eyes in a different way. So here's a short outline of what I'd like to cover today, but the outline is basically how I approach any patient that's referred to me for low vision, different things I want them to make sure they understand. These are people, and some of you are included, that have probably been to 2 or 3 eye doctors. You've had your primary care doctor refer you to a retina specialist, and the retina specialist has tried to treat your macular degeneration. And then basically when they're done with treatment, they say, well, that's all we can do. This is what you have left. And those of us that work with low vision get to work with what's left. So the title of the talk is, living with the low vision due to macular degeneration. So I'll touch just a little bit on the different types of macular degeneration. So I really don't want to have any questions on that because that's not really what today is about, but just a quick review of the 2 types of macular degeneration. But more importantly, how does macular degeneration affect your vision? How is it different when you have macular degeneration? We'll look at a few of the treatments. There's always questions on vitamins and things like that. But mostly I want to talk about, how is a low vision evaluation a little bit different than a normal eye exam? What am I interested in seeing? And then once I have that information, how do we train you to use the vision that you have left? And then what kind of vision aids might be helpful for you? The great American philosopher Yogi Berra once said, if you don't know where you're going, you probably won't get there. So I'm hopefully going to show you where we're going today. But, it's interesting. I see my patients come in, and again, they've been to 3 different eye doctors, and I'll ask them to tell me what's wrong with their eyes, and most of them can't tell me. So us doctors aren't doing a very good job of explaining what macular degeneration is and how it affects your vision. So you need to find that out. This is a condition you're going to have for the rest of your life, and you need to figure out how it affects your vision. So just a quick review of the anatomy of the eye. The light comes into the cornea and the iris and the lens inside your eye, and then it focuses back on the retina. And the very center of your retina is called the macula. It's the most sensitive area. But all those nervous impulses then travel through the optic nerve into your brain. So vision actually occurs in the brain. And so if you have other problems with your brain, such as a stroke or other conditions, that can affect your vision too. Macular degeneration does not affect the brain. It just affects the eye. So that brings up a lot of interesting dilemmas. But basically, the big one is something called Charles-Bonnet syndrome, when you suddenly lose the center of your vision in your retina. The vision part of the brain still works. So it's trying to figure out this distorted image that your eye is sending it, and it will actually make stuff up. And these are called visual hallucinations. So it's not uncommon for people with advanced macular degeneration who can't see detail well to be able to occasionally see things that really aren't there. And it's not a sign of dementia or psychosis or anything like that. It's just a nature of a sensory organ that no longer sends good information. And the analogy would be phantom limb syndrome. People who have amputated legs, they can still feel their toes, even though the toes aren't there, but the part of the brain that used to feel the toe still works, and it's trying to figure that out. Disease of the retina. So we're talking about that back part. And I think I told you about the optic nerve and the visual pathway. So I really don't need to go over that again. Statistics here, of course, macular degeneration, leading cause of vision loss in the United States. But you can see by the graph that it starts increasing mostly after age 70, and it goes up dramatically. 14% of people over 80 will have some degree of macular degeneration. And another number that's thrown out is about 1 in 3 people over 70 will have some degree of macular degeneration. Certainly tends to affect females more than males, whether that's just because females tend to live longer, could be, but certainly that seems to be the case. And then what's it projected to do? Well, there's about 2 million people at the last census. This is some of the information that census data will tell us, but by 2050, it's going to be almost twice as many people with macular degeneration. But the hope with time is we're going to have some new treatments for it. So different types of macular degeneration. You hear of wet and dry. So I'll basically just tell you the difference. They're both going to cause a distortion in the central area of your vision. But the majority of cases are going to be dry macular degeneration. So this is what I see when I look into somebody's eye, the round object with the blood vessels coming out of it. On the left is your optic nerve, but right next to it is the macula. And the macula is the most sensitive area of your retina. It has cone receptors, which are responsible for small detail vision, 20/20, and also color. But that's only about 2 to 5% of the total area that your eye can see. So that's very important. If you lose that small area of vision, that's your detail vision, that's your reading vision, you still have 90% of your retina that still works, but it's your peripheral vision, and it doesn't see, it sees differently. If you take a cross-sectional view of that retina, at the very center of the macula, there's a dip, and that's called the fovea. And that's your sharpest area of vision because the top layers of the retina are kind of pushed off to the side. But the very bottom layer of the retina, where the little box is down there, those are your photoreceptors. Those are the cells that turn light into nervous impulses. And the layer below that is a barrier layer called the pigment epithelium. And that's the area that's affected with both wet and dry macular degeneration. And I'll show you the difference there. Normally, that barrier layer separates a blood vessel layer below the retina from the sensory retina itself, and it allows oxygen and carbon dioxide to diffuse across to keep the photoreceptors happy. So when you look into an eye with macular degeneration, you're going to see something called drusen in most cases. So many of you have been told, well, you have drusen. Well, those are those little yellow spots, and those are accumulations of a fatty material, metabolic waste that can't get through that barrier layer anymore. And so that kind of clogs up the circulation and the oxygen and carbon dioxide exchange. So let's go into the eye, and we're going to talk about dry macular degeneration first. So there's a normal looking macula. We're going to zoom in on it, and then we're going to take a cross-sectional image of that retina. 90% of the cases of macular degeneration are going to be the dry type. So most of you probably have the dry degeneration. So if we zoom in on that photoreceptor layer, you can see those yellow spots forming, and those are the drusen. We're looking at it in cross section now. But as those drusen get larger, they tend to elevate the photoreceptors, and the more elevation there is, it will start to distort the vision. And these drusen tend to increase over time. So the longer you have macular degeneration, the more it affects your vision. So macula is the center of your vision. So you're going to see distortion. Things are going to be tilted a little bit. It's going to be kind of a darkened area or a gray area in the middle, much harder to see at night. And you zoom back out looking at it. When the doctor looks at it, we're looking at it in cross section with OCT cameras, but we're also looking at it like that. But over time, as you see a person every year, the area of drusen are getting bigger and bigger, so it affects more and more of your vision. At this point, using more light does seem to help, and even though there's probably a small distorted area there, you may not notice it. Now, your doctors have probably given you that grid called an Amsler grid, And that's a way to tell if there's enough distortion on the retina, it will bend those lines. And that's one of the only ways we've had to monitor macular degeneration at home. So everybody gets one of those Amsler grids because they're cheap, but they don't really give us all the information, and you have to be a pretty acute observer to be able to tell if there's changes going on. There are a few options for dry macular degeneration. The age-related eye disease study, or what we call AREDS 1 and 2, were the first studies that showed that certain vitamins, nutritional supplements, are helpful, and they basically slow the progression by about 30% a year. So everybody should be on AREDS 2 vitamins. The AREDS 1 had vitamin A in it, and the study later showed that excess vitamin A, since it accumulates in your tissue, can cause liver failure, and it can increase your risk of lung cancer. So in 2013, they did the AREDS 2 study, and they took the vitamin A out and they put lutein in. Lutein is a chemical found in dark green leafy vegetables, but when you eat lutein, it's water soluble, but your body turns it into vitamin A. So it helps your retina stay healthy. Protecting your eyes from ultraviolet, so having ultraviolet filters put in your glasses, and that doesn't mean sunglasses, it just means ultraviolet filters are helpful. Green leafy vegetables every day, try to eat a low-fat diet. Avoid smoking. Smoking definitely is a big risk factor for wet and dry macular degeneration. Interesting, there's maybe the first drug treatment we've had for dry macular degeneration. This Reclaim study is in phase 1 trials with the FDA. And this is a drug that works on the mitochondria in the retina cells. That's the power source of a cell. And they're thinking that may be one of the causes of the dry degeneration. So look for that study. And if you're in a larger city with a academic center, you might even be able to be enrolled once it's to a phase 2 or a phase 3 trial. And there's some of the vitamins that you've all heard about. You know, I don't have any favorites. I tend to use the I Promise products because we can get lots of different types. We can get more zeaxanthin and more lutein. Not really the topic of today, but a lot of people will ask about that. The standard AREDS 2 Preservision, that's what was used in the study. The I Promise and some of the other brands have just taken off on that same information and maybe increased certain ingredients. All right, let's go on to what's the difference with wet macular degeneration. Dry is very slow progressing, and it can take years for the vision loss to get worse. But here we are looking at the retina again. You're going to have drusen. Typically, only 10% of the cases are wet degeneration, but the drusen actually increases your risk of having wet macular degeneration. So what happens in wet is you have the drusen building up, and because the retina cells aren't getting enough oxygen, the retina starts to give off a chemical called a vegetative endothelial growth factor, which causes these abnormal blood vessels to start growing. And these blood vessels, like in diabetics, are very leaky, and blood will start to build up on the retina. And this can happen very rapidly. So it's in the same area. It may start out as a mild shadow in your vision, but it can very rapidly progress. So this is one that can progress in a matter of days or weeks from normal vision to very severe vision. And so obviously being able to detect this change in vision, you need to know. Now, interesting, a lot of people, because you have 2 functioning eyes, I see this a lot. One eye will go bad and the person won't really notice it because they're looking at things with both eyes. So, you know, once a week or occasionally when you're watching TV, maybe cover one eye, how's the right eye seeing, cover the other eye, how's the left eye seeing? And you'd be surprised, occasionally you'll notice one eye has worsened significantly. And so be aware of that. So some of the diagnostics, one of our sponsors today, No Television, their technology is basically making better home testing equipment where a person can even have small pictures of their eye taken remotely and sent to their retina doctor. The sooner you can get the wet degeneration treated, the better the outcome. Many of you are getting shots. I've had patients that have had 150 shots. So it's it's a wonderful. It used to be wet macular degeneration. You were going to be totally blind in a matter of years, and now we can actually stop the condition and keep it under control. But these endothelial growth factor blockers, that's what Avastin, Lucentis, Macugen, Eylea, that's what those are. They only last for so long, and typically they have to be injected every 1 to 3 months because they lose potency, or the body metabolizes out the chemical. I did see a low vision patient recently, and his son brought him in, and the son was from Denver, and he has wet macular degeneration. He said, "You may want to look at my eye." I didn't get a picture of it in for this talk, but phase 3 trial, they actually have an implant with the Avastin drug in it. So he just has this device implanted through the white part of his eye, and it's constantly dribbling out small amounts of Avastin inside of his eye without having injections. And his wet macular degeneration has actually reversed and has gotten better. So look for that as well, or talk to your retina specialist when that comes out. It's certainly would be having shots every 2 to 3 months, and that will be a big deal. Wet degeneration, we still want you to use the AREDS 2 supplements, green leafy vegetables, UV protection, and certainly avoid smoking. The patients I see with wet macular degeneration at a young age, they all tended to be smokers, and a lot of them still do. So what do we do with an impaired person? So you got macular degeneration. It's a disease. It's a pathology. And that's where your medical doctor works. If you have a disease, we try to treat it, either medically or surgically, to try to stop the disease, but it's going to leave some level of impairment. And impairment is the loss of vision. And that's what those of us in low vision do, is we get the patients after the treatments have been done and the person can't see normally anymore, but they still want to read. So optometry and ophthalmology does that, but there's still going to be some disability. You may not be able to drive anymore, or things like that. And some people, the vision loss is so severe that vision aids really aren't helpful. So we go into something called vision substitution. And these are blind rehab counselors that I'll refer people to. Occupational therapy also does this kind of work. If we do that, Medicare helps pay for the actual hands-on training or going into the home to suggest environmental adaptations. As you know, optometrists and ophthalmologists are the only doctors that are able to diagnose and treat eye conditions. And we understand vision loss and how you can make it better. But in a low vision exam, I'm always going to start with visual acuity. We got to find out what the person can see, and we want to know what each eye sees by itself. We're going to test them at distance and near using special eye charts. This is going to help me determine which eye is better, and that's important, and I'll explain it a little bit after a little bit. We're also trying to determine these things called scotomas, and these are the blind spots that form in your vision when parts of your retina no longer work. Once you know visual acuity, which is the better eye, where are the blind spots, we can better teach you the proper vision aids to use, but you need to be trained in how to use them. If you go to the store and buy a magnifier at Walmart, there are no directions with it. Which eye to use it with? How far do you hold it away? So there's value in going to somebody that understands how a vision aid works, and some of the things you can do. Another thing I'll talk about is if our center vision doesn't work, we can teach you how to look off center, and that's called eccentric fixation or sensory modification. So find the eye that works better, learn to look off center, then that becomes your new central area of vision. And then, of course, there's a lot of time involved. I spend about an hour and a half with my low vision patients from the time they check in to the time I've taken pictures of their retina and figured out which is the better eye. So it's a slow process. I've been involved legislatively with Medicare across the country, and there was a time when Medicare didn't pay anything to be seen, but more recently, at least in the last 20 years, low vision doctors can see you and bill the evaluation and training to Medicare. The low vision exam is basically going to tell me how much functional vision is present. And if you have enough, then adaptive aids might be helpful. Unfortunately, there are some cases where there's just not enough usable vision left to where we can actually use magnifiers to enhance it. And so we're going to suggest something called vision substitution or blind rehabilitation. So we don't like to use that term. Here's a picture showing normal vision, 20/20, whatever that means, up on top. But you can see somebody with 20/20 vision they can see most of the rows on that eye chart. They can see color. They have a nice big field of view. Then the bottom picture shows you that same scene at 2200. Now, there's a lot of information that's still there. You know, I can see 3 to 4 rows of the eye chart and read the letters. The color information is there. The peripheral information is still there. So even at 2200, there is usable retina there that's still useful. It's just not as sharp as you're used to, but that's what you have to get used to. It's a disability. We're going to use this chart. It's called the Logmar chart. It's become the standard chart for testing visually impaired people. There's the same number of letters on each line, and the space between the letters is proportional. So as you get smaller, the letters get closer together. And we might test you not at the normal 20 feet or 10 feet, but typically I'll test a person at about 1 meter. Makes the math easier for me. But the nice thing about bringing the chart closer is the person is going to be able to see more information. And again, you see we're testing one eye at a time with a controlled amount of light. Behind the patient, there's another kind of chart called a contrast sensitivity chart. And this is also very important in low vision patients. On that chart, the letters are the same size, but as you go down, they get dimmer. And as many of you know, you need more light when you have macular degeneration. So this is a way to measure how much light a person needs. And typically with macular degeneration, you may only be able to get the top 3 rows on that chart. If I have a patient that's wanting to drive, I'm going to use that chart for driver's license decisions too. So we check the far vision first, and then we check the near vision using a similar type of card, one eye at a time, right eye, left eye. And I'm going to make note of the distance. And the reason we always check distance, check the vision at 2 different distances is the letters are proportional in size from one chart to the other. So if I measure you at 1 meter and we see an 8 size letter, and then we test you at 25 centimeters, which is 4 times closer, that letter should be 4 times proportionally smaller. So 8 divided by 4 is 2. So if I get a proportional measurement, I know that my visual acuity measurements are accurate. On the kids at the School for the Blind, we actually measure them up close first because they like things close, and then we'll project that out to distance. But everything has to be, you always have to have a distance measurement for purposes of driver's licenses and Social Security, things like that. But that's why we test vision at 2 different distances. Then probably half of the patients that I see for just low vision, their refractive error or the prescription in their regular glasses is not up to date. And that's because they've been going to specialists and they don't really check those things. But we now have instruments in our office, electronic devices that can actually tell me what the prescription is. That's what the picture on the left is. And it gives me a very accurate measurement, especially in a child or in an older person who doesn't see very well. It's hard to tell, which lens is better, number 1 or number 2. We like to do the vision testing in a trial frame because we have more lens area to look through. So that's what I'm doing on the right there. We take that information from the autorefractor device, put it in, have them look at the eye chart, change the lenses one at a time, get the sharpest area of vision. Once you have the best prescription, that becomes their visual acuity that we use for reporting legal blindness or for determining a magnification that the person needs. The close-up chart actually tells me how much near magnification we need. So on this chart, the top row is called 1M, that's normal print. The bottom row says 2M, that means it's twice as big as normal. So if the person can only see the bottom row, that means I need to give them 2 times magnification to be able to read standard print. Now, as some of you know, as the lenses get stronger, the focal length comes closer. So that stronger that bifocal or the reading lens is, you sometimes have to hold things very close. And that's another problem that I tend to see when a patient comes in, even for just a regular eye exam. The bifocals are typically made for about 16 inches. So the picture on the left shows the patient holding the eye chart at where the bifocal is made for. But as her vision's gotten worse, look at the picture on the right, she's just kind of learned to hold things closer, and she's now twice as close as she is on the left. So if I measure that distance, I can calculate the bifocal power. And so many patients, we just give them a stronger bifocal, and they're very happy. They can go back to reading again. And in early cases of macular degeneration, mild to moderate cases. So knowing the distance and just giving the patient the card and holding it where they say they see it the best, that's where I take the measurement, and that's where I figure out how much reading add they can. If we can make a bifocal work or a pair of reading glasses, patients already know how to use that. They don't have to use another hand to hold an optical device. Another interesting thing that I've learned over the years is, as an optometrist, we're taught that, well, you always have to have the eyes work together. We're binocular, in a normal situation, most of your life, your eyes did work together, and that's what gives you depth perception. But when you develop macular degeneration, one eye may see better than the other. So in this picture, it shows that the right eye has a bigger dead spot than the left eye. And if you're trying to read with 2 eyes, the letters are going to jump in and out because there's a dead spot in the left eye, and then as you read across the page, there's another dead spot, and you lose your place very easy. So it's much easier to cover the right eye in this case, so you only have one dead spot to look around. So when we take these pictures of the retina and you do those grid tests, that's telling us where the biggest dead spot is. So that's how we use it. So one thing I teach eye doctors when I lecture to them is it's okay to cover an eye. If in this case, if that person's left eye sees better than the right, and the right eye is actually interfering, the best way to do this is give them a newspaper. And I've seen people with very dominant right eyes that are 2200 from macular degeneration, and they're 20/20 in the left eye. They will continue to try to use their bad eye. And these are the patients that come in and they say, Doc, I see better if I close that right eye. So that's just a simple thing we can do. Obviously, we don't want you to walk around with a big patch on your eye, but we can put sector patches. So the picture on the right shows just covering up the bifocal in that case. And there's some filters called Bangerter filters that kind of fog the vision on one side, but yet you can still see the eye behind it. And they're used for treating lazy eye in kids, but it works very good for macular degeneration too. So, after the lecture, go look at your TV or a calendar and, compare one eye to the other. You may be surprised that one eye works better. The visual acuity is going to tell us lots of things. It's going to tell me where you stand. It's a way to determine progression. If we look at the eye chart on the right, the definition of legal blindness is when you cannot see 20/100 or better. Social Security uses 20/200 as the definition of statutory legal blindness. But they changed the rule in 2007 because we have better eye charts now, that if you can't read any of the letters on the 20/100 line, then you, in the best eye with the best correction, then you are considered legally blind. So we'll send a letter home with the patient, go talk to Social Security. They can help you a little bit. Legal blindness, even if you have 20/20 vision, there's also a definition that if your visual field is constricted to no greater than 20 degrees diameter, then you're also considered legally blind. And that's what the picture on the left shows, just a very narrow field of view. Typically glaucoma, or that's typically glaucoma. Macular degeneration, you don't lose the peripheral vision. So that's acuity, why we want to find right eye, left eye, which eye is better. The next part is the scotomas, or the areas in the field of vision that no longer see clearly. So the picture on the left is a typical dry macular degeneration. The central part of this person's retina, that's his right eye, no longer works. So when you look at the grid, there's going to be a distorted area. So that's what you're looking for on that grid. Remember, when you use the Amsler grid, you always use one eye at a time. You can't do that test with both eyes. So some of the home monitoring systems, the newer ones that are coming out, they don't use the Amsler grid. So that's going to be a real breakthrough, especially on those patients that are developing wet. And we want you to check that vision every day, because at the first sign that it's worsening or you're getting more distortion on the grid, we got to get you to the retina specialist. And in my world, in rural Western Kansas, the closest retina specialist is 3 hours away. So it's we have all the instrumentation. We can take the images of the retina. I can electronically send it to the retina guys in Wichita, but the patient still has to get there to get the treatment. So this is an Amsler grid that I developed, and instead of having a dot in the center, it has a letter. And the letter is actually standard size print. So I'll give this to a patient, but I won't tell them, because they're used to seeing a dot in the center. So I'll say, here's a grid, what do you see in the center? And they'll say a dot. So if they say a dot, then I know they can't see the letter P. But the interesting thing about this is, if you can see that letter P, then we know the central part of your macula is still working. And another thing we can do with this is, I talked earlier about, if you can learn to look off center, you can move the dead spot from the macula into an area where it gets out of the way. So this chart helps me teach people how to look off center. The size of the scotoma determines how much magnification there is. So the top row, the word is magnify, and there's a dead spot over it. So that's normal size print. Next one down, we're magnifying the print 2 times, then 3 times, then 4 times. So basically all your magnifiers do, optical magnifiers, is they make the print you're looking at bigger than the dead spot. It doesn't make the dead spot go away. So the person is still going to say, well, it's kind of moving around, or there's a spot in my vision. And then remember, they may have 2 eyes doing it. So remember that. That's all magnification does. Another thing you can simply show a patient is when I set right in front of the patient, and I'll say, describe my face. And they say, well, it's all distorted. And I say, well, look up to where my hair is. And that moves the distorted area out of the way. And they say, well, wow, now I can see your eyes. And most people, when they come in for their low vision exam, they have not learned to eccentrically fixate. So basically, by changing the direction of viewing or looking slightly off center, can actually allow you to use part of your retina that still works. Your macula is very tiny area. It's about the size of the head of a pin, but it's the most detailed area of vision that you have. And your brain very much wants to, when you look at something, it wants to point your macula, and it's done that for your entire life. It points the macula right at what you're trying to see, and now that area doesn't work. So with a little training and understanding, by teaching you to look off center, that will become second nature, and your brain will kind of recircuit itself and say, you know, if I look up a little bit, I can see better. So using some of these diagnostic tests, we can determine which way the person's looking. A simple way to do it is on the left. That's called the clock dial method. You just put a word or a letter in the center of a clock dial, and then you just slowly, look at the 12, look at the 1, look at the 2, and you try to find the direction where that letter in the center looks better. And then you've actually taught yourself which way I need to look. On the right is the OCT camera, and it's going to give me a live image of the inside of the eye. So many of you have had OCTs done. It's the thing with the red light. It's a laser that looks in, but it's a live image. So when the operator is running it, we see the images that you see here. So this is the same patient. Their right eye is on the left side. Their left eye is on the right side. And the white area in their macula is the dead spot, or the scarred area. If you remember, when you look into the OCT, you actually see a blue dot, or a fixation target, we call it. So we tell the patient to look at that dot, And then I'm seeing the image of which part of the retina they're using. So on the person's right eye, the left picture, you can see where the cross is. They're actually using a spot above the scar. So that tells me that person's learned to look up. On the left eye, they're using an area between the optic nerve and the macular scar. So that's not a good place to be, because you're kind of got tunnel vision there. So number wise, the right eye can see 2200, the left eye can see 2040. So before 2400. So I'm going to pick the right eye in this case. That's the eye I'm going to tell the person to use with their magnifier, and we'll give them some practice exercises at home to teach them to consistently look off center. Believe it or not, this has been studied in eye care science pretty heavily. A lot of work has come out of Sweden, believe it or not, using the scotomas, and one of these large scale studies, and there was one that came out of Don Fletcher in the United States, ophthalmologist, did a similar study of about 800 patients. What they found was when people came in for their low vision exam, 39% of them had learned to look up. So when they look at that grid, the dead spot's above it. The next most common direction is to the right, 33%. So almost 75% of people are either going to look up or right. So if you want to bet, look up or right, you're going to see a little bit better. And then 20% look to the left, and looking down is only about 8%. But the best direction is either up or to the right, because in our society, we read from left to right. So that works better to have the dead spot above or below. This is actually what's happening. This is looking at the eye from the side. So person's trying to look at the star, and they've got on the right side there in the eye, you can see that's where the scar is. And the scar causes that dead spot in your vision. So simply by having them turn their eye up, it rotates the eye, so the image of the star is hitting the part of the retina that can still see. So we've actually moved the dead spot up by looking up. So look towards the dead spot and you'll see better. And this is looking at it another way. If you're trying to read that print, if you just learn to look at the top edge of the letters, you're going to move that dead spot out of the way. Now, remember, everybody's dead spot is in a slightly different position. It may be bigger or smaller. So that's where it takes a professional, somebody that deals with this to try to teach you through it. What can we do? Well, you can get so once I've determined the acuity, better eye, which is the best direction, then I'm going to jump into vision aids. And, most people know how to use bifocals, but you can get bifocals 10 times stronger than a standard one. The nice thing about that is you have both of your hands free. You just have to learn to hold things very close. And this is a picture of my dad, and he had macular degeneration, but he was using a 20 diopter lens. So he had to hold that reading print about 2 inches away. And basically the limiting factor was his big nose. That can be something that can be helpful. So standard bifocals, we can get them much stronger. Even no line bifocals, you can get them twice as strong as what a standard strength is. Because we're dealing with the retina and light scatter, filter lenses are helpful. Now, these aren't sunglasses. These are specific filters that cut off certain wavelengths of light. And these are called blue blockers. These are prescription blue blockers. When you have a distorted retina, it tends to scatter light, and the blue colors, short wavelengths, are scattered more. That's why the sky is blue. The sunlight comes in, the particles in the atmosphere scatter the blue colors more. So, and that can be very disabling to someone with retina disease. So these glasses do not cut the brightness of the light. They just remove all of the blue. And these can be very significant. And then they range from the yellow, orange to kind of an amber. And so we'll suggest these in some cases. This will actually help. The yellow ones sometimes help with night driving, especially with the LED headlights that we see now. There's a lot of scatter from those. Lighting is huge. We talked about most people have low contrast. And so special lighting like Chromolux, which are full spectrum. How many of you say, I can read better if I go out in the sunlight? Well, that's because that's a full spectrum bulb. And now you can go to Home Depot and get LED bulbs that do the same thing. The nice thing about the LED is you can get the same brightness, but there's another description of a light bulb, and it's called color temperature. And that's what soft white or cool white or daylight. The soft white is the yellow. You don't want that. Usually the cool white or the daylight are going to give you better vision when you have low vision or from macular degeneration, and how close you can get the light to your reading material. So if you, let's say you have a better seeing left eye, I would bring the light in from the bad sides, from the right side, so it's not shining directly into the left. Get the light close. Very common stand magnifiers. These are probably the number one thing we use on moderate macular degeneration, and there's different types. The bottom right is called a dome magnifier. Basically, it just sets right on the print, magnifies about 2 times. The one above that is a little bit stronger one that you can actually write underneath. But the most common ones are the lighted stand magnifiers, and those are the ones on the left where there's actually a light source and a magnifier built in. And so many of you probably have used those. Be aware that they do have LED lights. That's the one that's a little bit bluer, and you can still get halogen lights on them as well. I like the Eschenbach products. They're the German made, they're precision, more expensive, but they give us a lot of information. So this is the magnifying head of a lighted stand magnifier, 2 different ones. And I'll always tell people, which one's stronger? And 9 out of 10 people are going to say, well, the one on the left because it's bigger. That's not correct. The one on the right is stronger. As the lens gets stronger, it gets thicker, and you can't make it as big. So the stronger the lens, typically the smaller they are. The nice thing us doctors like about the Eschenbach products is on the neck there, you can see some numbers. So the one on the left says 3x. That means it's a 3 times magnifier. It's a 12 diopter lens. And so we need to know the optics of that. And then the third number is the distance that you hold your eye in millimeters. So the one on the left says 250. So that means when you put that magnifier on the print, you want your eye about 250 millimeters, 25 centimeters, which is 10 inches away from the lens for it to work the best. The one on the right, the 10X, it's at 40 millimeters. So as those lenses get stronger, you have to bring it closer to your eye to see with it. So that's how you use a stand magnifier. You want a reading stand or a clipboard. And the important thing about these is you're only using one eye when you look through these. So you have to make sure it's in front of the best eye. So again, going back to our very first test, which is the better eye, which has the dead spot you want to control the best. So that's the eye that you would use a stand magnifier with, and make sure you have it at the right distance. Sometimes you have to use your glasses depending on your prescription of your eyes. If you're farsighted, then you may need to still wear the glasses when you use that magnifier. If you're trying to see things that are far away, we'll use a telescope, and when they're mounted in a pair of glasses, we call that a bioptic telescope. So you can walk around with it. And then when you want to see something far away, you just tip your head down and look through the telescope. The one on right is more of a custom made one I made for a patient a few years ago. Designs for vision are the ones you probably see a lot. The one on the left is a flip telescope, which is really neat. It's a low power telescope, but you can flip it up and down, and it will magnify about 2.5 times. And so 2.5 times takes a 2100 patient down to 2050. And in some states, you can actually drive with that. This company, Ocutech, is out in North Carolina, and they've had some of the more innovative products. So the Ocutech Flip, it's one of their products. Instead of having a round telescope that projects away, they've made these folded optical designs in their bioptics, and these will actually focus up close. And so these are called the VES or the Explorer. You can put your eyeglass prescription in a bifocal in the lens, and then you have the telescope in the upper part. So we can go up to 4 to 6x on these. So you can take someone with fairly poor vision and get them back to the 2050 range. You never want to take somebody all the way to 2020. That's just too much magnification. The downside of magnification is the more magnification you have, you reduce the field of view. So it's like looking through a pipe or a straw. This is their newest offering. They've had one of these in the past. This is the autofocus version, what they call the Falcon. And these are truly amazing. You can get it in 3, 4, or 5x. It has a image rangefinder in it. It's a battery powered device, but no matter where you point this thing, it's always automatically in focus. Again, it just only works on one eye, but for if you're trying to look at computer screens and then looking up in the distance, students where they're looking at class in a classroom situation, going to meetings, going to church, things like that, that can be really nice to have something with flexibility. Most of our optical devices are fixed focus, so they work for one thing. Many of you may have explored what we call closed circuit TV or electronic magnifiers. And these are basically just cameras that will use electronics to increase the image. And they have ones that plug into your laptop, so they're portable, and you can use them to look at faraway objects, or you can turn the camera to look down at a page, increase and enlarges it on the screen. You can get ones to do avocational type things where you can use your hands. The one on the left is the most common one that you'll see. You put your reading material on the table, it enlarges it up on the screen. The newer ones now have text to speech. So if you're really having trouble reading, it'll scan the document and actually read it to you, which if you're looking at getting one of those, make sure you get that feature. Even if you don't need it now, it's nice to have in the future. You know, tablets and iPads and things like that have changed a lot at the School for the Blind. Instead of having textbooks, the students just get iPads and they get all of their textbooks. Audible.com has a service where you can get books and publications in electronic format. So once you can get it on your iPad, the iPad will read it to you. That's built in. You can vary the size of the print just by pinching it and making the image bigger or smaller. Here's one thing I'd like you to, if you don't get anything else out of the talk, write this down. Microsoft makes an app for a smartphone called Seeing AI. And of course, we know AI means artificial intelligence. This is a free app you put on your phone, and it is simply amazing. It turns your smartphone into a text-to-speech machine. It will recognize people. So once it learns somebody, it has a mode where it recognizes things. You can hold it in front of a printed document and it will read it to you. It just starts reading in document mode. It will even read handwriting very accurately. If you take it to the store, it will read barcodes and tell you what it is. And then there's even a mode that if you're outside, they have volunteers that will describe the scene of what you're seeing. So, yeah, get that. If you have a smartphone, an Android or a Mac or an Apple iPhone, it's free download. Seeing AI, just do a web search and you'll find it. And it's just simply amazing. And as we talked about people with very severe vision loss, we talk about vision substitution. Well, instead of trying to magnify something, this just reads it to you. So we're substituting being able to see it to being able to hear it. One of the head-worn devices that's relatively new is the Iris Vision. And I was involved with a project at Johns Hopkins years ago with NASA where they developed the first head-worn system called the ELVIS, the Low Vision Enhancement System. And it was way ahead of its time, but the technology was just too cumbersome. Well, this is now using VR goggles, which all of your grandkids have, and it uses a smartphone. The Samsung phones have the best cameras, and basically it's taking a live image of what you're looking at and it's magnifying it on the screen. The lady on the left is actually reading a newspaper. It will take an image of a newspaper and then it will freeze it. And then you can zoom the print up as big or as small. And just by moving your head around, you can look at different areas on the device. You can use it for reading, you can use it for far away. But because it responds to voice commands too, so you can tell it to zoom up or zoom down. So there is a barrier with technology. You got to learn to use it. But this thing can do you know, it's not for everybody, but for certain tasks, this might be the best option because you got your hands free. You're not going to drive a car with it. Here's another vision substitution device called OrCam. This doesn't use vision at all. It has a little camera that you put on your glasses, and you have that little electronic box that you just put in your pocket. This is kind of like going on Facebook, and whenever it sees your picture, it says, well, there's Bob. Every time it sees a picture of Bob, it says, there's Bob. You train this device to recognize things. You can hold a newspaper up in front of it, and you touch the newspaper with your finger, and it scans the entire page, and it's all voice output. It's reading stuff to you, or it's describing things through your ears of what it sees. And you know, the iris vision is $2,500. The OrCam's probably $3,500. And in the big scheme of things, I just got a pair of hearing aids that cost me $4,000. So, you know, so the vision stuff is expensive, and unfortunately, insurance doesn't cover this. But there are some ways around it. But that's some of the new technology that's out there. The final thing I'll talk about, not much, is people always say, well, why can't you transplant a retina? There's a company called Argus that is making a retina prosthesis. They put a little chip inside your eye on the damaged retina. You wear a pair of glasses that take a picture of the world, and then it stimulates the retina so you can actually see things. Now, it's kind of like looking at dot matrix. You're just seeing dots. You can see outlines. So for a low vision person, this has no place. For a totally blind person, it could allow you good enough vision to navigate. Medicare actually pays for this thing, which is pretty amazing, but you've got a piece of metal in your eye, and then you got to get power into it. So it's a surgical procedure to get it in there. I was at a conference in Phoenix here a couple of years ago. The inventor of this device, they're now making a cortical implant. So if you've ever seen a deaf person who has the hearing aid where it goes directly into their inner ear, they are making a device like this where there's a camera that then puts the signal directly into the visual cortex. That's groundbreaking stuff because it completely bypasses the eye. So no matter what eye disease you have, there's going to be a way to get the image into the vision part of your brain, which likely still works. The problem is it's just not a simple wire that goes into your brain. They're learning the coding and the software to take an image and translate it into something that the brain can recognize. So in closing, that's just a very short overview of some low vision stuff that's out there. I think it's really important that you have a team. You have a degeneration. And if you look up the word degeneration in the dictionary, it's going to say a medical condition that gets worse. So you need to have a team that if your vision gets worse, if you're monitoring at home and you wake up next Wednesday and you can't see out of one of your eye, what do you do? I ask my patients, what would you do if you woke up? Who would you call? So you need to have that team. You need to know who to call, because with wet degeneration, you need to act rapidly to be able to save the vision that you can. Make sure that your retina specialist sends you to someone that does low vision and is good at it, because there are some of these tricks that I've shown you that you've maybe never been aware of that you can do. And that's what us low vision people do. Make sure you monitor your vision, do the supplements to try to slow the progression. And then you're basically doing everything that you can. Hopefully I've taught you that most people have two eyes, and you want to try to figure out the one that works best. And that's the one you use with your vision aids. Make sure you understand how to use the vision aids. There are aids that you use for distance and near. There's not too many that will do both. And you may have multiple aids depending on what you're trying to do. Learn to look off center. If you have macular degeneration, most of you have probably already learned to do it. You just don't know that you are. It does develop on its own, but we try to guide it to where we're using the best eye. And increasing illumination is always very helpful. Look at some of the resources. The Macular Degeneration Association. You go on their website, click the resources page. You're going to have so many resources you can look at, anywhere from eye research topics to rehabilitation to suppliers, sources of where studies are going on. So a great organization, please utilize it. And I think they're doing a great job with getting the word out to people, because you develop a condition, no matter what disease you have, you feel like you're alone. And you want to try to find answers. And once you get over the fact that it's not going to get better, then we start looking. And unfortunately, eye care professionals and our society in general just hasn't done much for vision impairment and blindness. So fortunately, we have organizations that are stepping up and trying to make this more available to people. So with that, I think I'm done with my part of the presentation, and I see that there are a few questions coming up. Can I have both macular degeneration and retinitis pigmentosa? My sister has one and my mother's twin had the other. Well, that's a good question for your retina doctor. And yes, you probably can. Retinitis pigmentosa tends to come on much earlier, usually in your 30s and 40s, and most people are significantly impaired or blind by the time they're 50. It is a retina degeneration, but it affects the peripheral vision more. The macular degeneration tends to affect the central vision more. So yeah, I suppose it's possible. It probably depends on your age. You don't want retinitis pigmentosa. It's very rare, and it always leads in blindness. So can drusen be removed? My doctor told me that there is nothing more he can do, but I'm having trouble seeing. Well, reduce your risk factors. Go to a low-fat diet, start your antioxidants or your AREDs too. Now, interesting, 20 years ago, there was a eye research out of Germany that they actually did dialysis, and you would go in for about a 2 or 3 hour treatment where they would actually remove the lipids from your bloodstream, and that's done for people with very high cholesterol. And they actually showed that they can remove the drusen. It was never FDA approved in the United States, so you can't get that here, but they still do it in Germany. So you would want to look at doing a search for that. Remove drusen through a dialysis type of question or a query and see what comes up. And I've had a couple patients that were willing to travel for that. The problem is you got to have these treatments 3 to 4 times a year to remove the drusen. So what low vision products will help me see? I'm treated for wet macular degeneration. Well, hopefully, I think that question came in before I was through that part of it. So hopefully you saw that there's lots of different things that can help you to see. It won't make you see better. Low vision aids basically allow you to access things that you couldn't see with your normal vision that you have now from the macular degeneration. So you're always going to be disabled from the macular degeneration. You're not ever going to get that vision, detailed vision back. You have to just learn to use what you have and enhance what you're looking at to where your current function will allow. I have been told that I suffer from low vision. Can I still drive? Well, that's a good question. Depends on lots of different things, and it depends on the state that you're in. The laws are different in every single state. So the ability to pass a driver's license exam is basically the central acuity test. Every state requires that. And most states, you have to be able to see 20/50 at a minimum or 20/60 in one eye. Commercial drivers have to have 20/40 or better in both eyes. So a standard driver's license, it's going to be 20/50, 20/60. So if you can't pass that at the exam station, then they're not going to give you a license. Some states also check peripheral vision. So that's a question for your eye doctor. And typically the eye doctor is going to pass you off to a low vision specialist. If you're, I did 2 of them yesterday, basically eye exams to complete a driver's license form. In Kansas, we can do drive testing, which is the most accurate way. So if you have a visually impaired person, if they don't quite qualify by the 2050 standard, they can still get a restricted license, but they actually have to go on a drive test with the examiner, and then they have to have their license renewed every year. So it's possible. Depends on lots of things. I want to stay in my home but have trouble seeing. Who can I reach out to for help? Well, again, get into the system. If you have your eye doctor refer you to a low vision specialist. The low vision specialist is going to be tuned into the state services for the blind, both for seniors or vocational age people, or they can refer you into occupational therapy in your local region who does low vision. So there is help out there. And the goal of a lot of the programs, I know in Kansas anyway, we have a program to keep people independent in their homes by giving them vision aids. And so they actually give them the devices if it will help them stay in your home. So that's the goal. But check with the occupational therapy at like a rehab facility. Ask them if they have anybody that does low vision rehabilitation. If not, ask your eye doctor if they can refer you to an agency or to a doctor that does low vision rehabilitation. That's where all the referrals come from. Let's see. I like this next one. Would you like to come to Bend, Oregon? It's beautiful. Probably not an option. So how do we find a low vision specialist in our area? Where that might be? Thank you so much. Well, do a web search for low vision specialist in my area. You can look up American Optometric Association. There's a group of us in our national association that there's a directory for low vision doctors from across the country. Macular Degeneration Association probably has a resource list of people close to you. So again, probably good questions for your eye doctor. A lot of times people's vision goes bad. People will lose their vision and they'll stop going to their eye doctor. So try to find somebody in your area by doing a search for it. Ask your eye doctor. There are low vision support groups. There are national organizations, National Association for the Blind and Visually Impaired. They have national conventions. They have resources for things like that. But, that is a big problem in this specialty is there's just, in Kansas, there's about 5 of us that do low vision in our practices, and we're scattered across the state. So what about mid-range vision challenges, particularly on the computer or watching TV? Reading the guide. I wear the progressive lenses, but would like a single lens would work best for these situations. Well, you're actually at intermediate distance, and you're using the upper part of the progressive lens. So you're not using the reading part. So you want to make sure that your distance part is as good as possible. The simplest type of distance magnification is just that closer. If you go from a 10-foot distance to a 5-foot distance, it's magnified 2 times, and that's still within the capability of your standard distance prescription of your eyeglass lens. That's also what you would do at the computer. Now, at the computer, the closer you get, you do have to at some point have a prescription. You have to account for the distance prescription, and then the close distance we can add to that. Depending on the operating system of your computer, if you go in the settings, most of them will have disability settings for low vision. And it's a simple way to increase the contrast and the size of the print on your screen. And that's built in to every computer operating system that's out there. But go into your settings. There is software that you can add to a computer that are called screen enlargers or screen readers that actually read it to you. But I'm in the Macintosh world, and pretty much anything that pulls up on the screen, you can highlight it and click on it and it will just read it to you. So yeah, that's, I congratulate people for using computers. Get as big a monitor as you can. You can go to Walmart and buy a 32-inch TV now for $100, and if it has an HDMI cable, then that can become a giant computer monitor. You just have to have some way of getting your output from your computer to the TV, but HDMI solves a lot of that. So try some of those things, but just making the screen bigger by going from a 16-inch to a 32-inch, that's amazing. And then if you can tweak the size in your settings, it sounds like you maybe still have a pretty reasonable vision. And then you need to tell your eye doctor, I've got my monitor at 20 inches. I need to be able to see at 20 inches. They can make a pair of glasses that do it. The glasses do not magnify. They just focus for the closer distance. What size TV should I have? My vision is 2100. Okay. Get the biggest one you can afford, and then don't be afraid to set closer. Because at 2100, if you are setting at 10 feet and you move up to 5 feet, your 2100 becomes 2050. So assuming the size of the screen hasn't changed. So the take home message is don't be afraid to set closer. That does not hurt your eyes. The closer you get, the more important your eyeglass prescription is. So make sure that it's up to date. What is the best place to get magnifiers from? Well, hopefully from the presentation, you noticed that you can go online and you can, LS&S, different suppliers, you can buy these magnifiers. The question is, you need to know which one that you need, which one's going to work for what you're trying to do, and then you still need to learn how to use it properly. And unfortunately, there are no directions that come with that. So where's the best place to get it? I would have your eye doctor suggest a magnifier, and then some eye doctors do sell them through their practices, or you can go online. A lot of my patients, I say, well, you need a 5X Eschenbach lighted stand magnifier, and they go online and get it. There's a lot of Chinese stuff out there now that's a quarter of the price of the Eschenbachs, but they calculate the magnification differently. So on the cheaper magnifiers, usually the magnification is one less than what's listed. So if they say that this is a 5X magnifier, it's actually a 4. So you need to have somebody that can translate that for you, find out the strength that you need, and then go looking for it. But you can get those without prescriptions. Are the telescopes removable or fixed? Well, a couple questions I would have on that one. Some of them will flip up and out of the way if that's what you're talking about. Some of them we actually drill a hole through the carrier lens of the glasses, and it's more of a permanent. The advantage of those is they don't get out of adjustment as much. And remember, these will focus, but you also have to get it in front of the eye and make sure it's centered, dead centered in front of the eye. Now, typically on a bioptic telescope that you walk around with, it's not right in front of you. It's setting slightly above your line of sight so that you can still see below it. And then when you want to zoom in on something, you just tip your head down and look up. So it's kind of the opposite of using a bifocal where you look down to read. So then the other part of your question is fixed. And so there's a couple of ways eye doctors look at that word fixed. It could be fixed focus, meaning it's only set for one distance, or you can focus them. And all of the ones that I showed you are focusable. You either grab the barrel and turn it, or there's a knob that you focus. And I think those are more usable. Yeah, you got to learn how to focus it, but you can use them for different distances. So you could use it at a computer screen if you wanted to, or you could focus it for your TV distance. The problem with the telescope is it does limit your field of view. So, why would you not want to use it for the TV? Well, you can, but you're just going to see part of the screen because it's magnified so much. How can I find out more information about the OrCam? Just type in OrCam on your computer, or have somebody do it. There's a website or a phone number you can call. You can maybe ask your eye doctor, but probably they don't know anything about it. OrCam is actually invented and made in Israel, and it's been around for 5 years. If you have trouble, I can leave a resource. We might look on the the Macular Degeneration Association resource page. It might be in there. I can't tell you off the top of my head, but I can certainly forward the information to a Macular Degeneration Association and they can get it to you. So yeah, it's a pretty neat device. It takes a little bit of learning curve, but once you got it dialed in, it can do a lot of neat stuff for you. What is the difference between central vision loss, blurry spots, and scar tissue? Well, they're from the scar tissue causes the blurry spot. So when you scar the retina, it doesn't see sharply, and sometimes it'll actually be a dead area or it will be a distorted, blurry area. So they're the same thing, but one is the cause and one is the effect. Will I be independent of others, crossing streets and cooking? Well, that's a good question. That's a really open-ended message or question. It depends on your level of vision. If you're having trouble crossing the street, you need to consider using a white cane and learning how to use it. That's a way to extend your sense of vision by using touch. Not that you want to use a white cane, but the other thing about white canes is people recognize it and will yield to it. So there are blind rehab agencies. Most states have services for the blind agencies as part of their health departments. And I know in Kansas, you can actually get referred to that program, and at no charge, they have blind rehab counselors that can come out to your house or your home, teach you how to use some of these things, help you to get the devices. If you're wanting to be more independent with mobility, they can refer you to orientation and mobility, and that's a rehab specialist that treats people or teaches people how to that are having mobility issues. So you got to be really careful because you don't see well. You can trip and fall and break a hip, and then you're in the hospital. So the goal of mobility training is to improve your ability to get around with your vision loss. Somebody missed my email. Can you please give again? Okay, maybe we can put that back up. But it's kkrug@krugoptometry.net. Does sugar make your vision worse? That's a really general question. If you're diabetic, yes. If you're not diabetic, sugar gives you energy, and it's the mitochondria in your cells that make your retina work. That and the pigmentation or the vitamin A pigment in them. So moderation on everything. So I've never been asked that question before. So, but if you're diabetic, you got to watch your sugar intake. Is lutein good for eye health? Of course. Yeah, we talked about that. That's part of the AREDS. It's been studied widely. There's lots of supplements out there. 10 milligrams a day is what the FDA recommends, but you can take more. It's water soluble. Do you take it when you don't have macular degeneration? That's a tougher question, but it's not going to hurt you. But once you have retina disease, yes, you should be taking lutein. Lutein is in the AREDS vitamins.
We want to thank Dr. Krug for speaking with us today, and everyone stay safe and have a wonderful day.